Brash signs seen in laryngocele, angiofibroma, chronic tonsillitis, post-cricoid carcinoma. Answer of this question is laryngocele. If you compress this laryngocele from external pressure, the gurging sound will be there by air released from the laryngeal ventricle. This sign is called Bryce sign. Laryngocele is a rare condition characterized by benign dilatation of laryngeal saccule. It may be asymptomatic in majority of patients but could present with neck swelling, hoarseness, cough, and stridor. Clinically, three types of laryngocele has been documented: internal, external, and combined. It is commonly seen in glass blowers or balloon blowers. This condition, first described by Virchow in 1867, and this term coined by the Virchow also. There are no accurate figure available for India, but it's common in males. Male to female ratio is 5:1. Peak incidence during 5 to 6 decades. Laryngoceles are known to be intimately associated with laryngeal saccule. In two terms, laryngeal saccule is an appendix of the laryngeal ventricle located between the false chord and inner surface of thyroid cartilage. Laryngoceles could be possibly result from abnormally large saccule that extend above the level of thyroid cartilage. These structures communicate with laryngeal lumen and are filled with the air. These laryngoceles could be congenital and acquired. The saccule is lined by pseudostratified ciliated columnar epithelium. It also contains numerous mucous glands in the submucosal areolar tissue. These glandular secretions keep the vocal cord moist and lubricated, hence saccule is known as oil can of the larynx. Clinically, laryngocele are incidentally discovered during routine laryngeal examination. Symptom may present with hoarseness of voice, cough, foreign body sensation in the throat. External laryngocele may present with neck mass. Large internal laryngocele may present with airway obstruction. Laryngoceles are three types: internal, external, and combined. Internal laryngocele is completely inside the thyroid membrane. External is coming out from the thyroid membrane, present as lateral neck mass. And combined laryngocele having both component, internal and external. If the communication between laryngocele and laryngeal lumen get occluded, fluid may get accumulated within the sac. If accumulated fluid is mucoid in nature, then it is laryngomucocele. If it is filled with pus, then laryngopyocele is used to describe this neck mass. Laryngoceles are rare in infant. If they are found, they are invariably congenital in nature. They must be carefully differentiated from saccular cyst. These congenital laryngocele may be managed conservatively provided there is no airway compromise. If saccular cysts are present in infant, they must be decompressed and aspirated. Difference between laryngocele and saccular cyst. Laryngocele are filled with the air, common in adults, and this sac communicate with the laryngeal cavity, while in saccular cyst filled with mucus, common in children, and sac does not communicate with the laryngeal cavity. Radiologically, you can do high resolution ultrasonography. As you can see in this picture, there is hypoechoic lesion in the right side of the neck. You can do CT scan, that is most commonly delineation of the cystic with the laryngeal architecture can be done with the CT scan. You can see in the CT scan there is air filled sac in the neck extending into the interior of the larynx. So by CT scan you can clearly define the spatial relationship with the mass with the larynx. And MRI allows better characterization of soft tissue abnormalities. So you can do MRI, which also differentiate with the coexistent laryngeal malignancy. If there is necrosis, can be seen in the MRI. Management of laryngocele. Laryngocele can be managed by endoscopic approach or external approach. External lateral neck approach is better because there is excellent exposure, minimal morbidity, and there is reduced chances of recurrence. While endoscopically you can do CO2 laser marsupialization of this laryngocele, and you can manage both component, internal as well as external component, by the endoscopic approach. If laryngopyocele is there, then you have to give intravenous antibiotics and dexamethasone with needle aspiration of the external component if feasible. Following resolution of the infection, a delayed excision of laryngocele is advised.